This podcast is made thankfully to the BioVoyager company. Welcome back. I am Maya. Today we are arguing over a July 2026 open access review in Current Atherosclerosis Reports by Huige Li and Ning Jia at Johannes Gutenberg University in Mainz. The title is Social Isolation, Loneliness, and Subclinical Atherosclerosis. Dan will stay conservative on therapy. Alex will push the translational case. First fact on the table: this is a narrative review, not a new imaging trial. Dan, what is the paper actually trying to do?
It is trying to build a bridge. We already know isolation and loneliness associate with heart attacks, stroke, and death. The authors want to know whether that damage is visible earlier, as endothelial dysfunction, stiff arteries, carotid intima media thickness, plaque, and coronary calcium. Then they stack mechanisms: HPA axis, autonomic imbalance, CTRA inflammation, oxidative stress, nitric oxide loss, and biological aging.
And that is the right question for longevity. Clinical events are late. If social disconnection is already writing calcium and plaque in midlife, then loneliness is not only a mental health problem, it is an atherogenic exposure. The paper is a map of that exposure.
Question 1: overall purpose. They say event associations are established, mechanisms are not. Is that a real gap?
Yes. Interheart put psychosocial stress near the top of modifiable infarct risk. Meta-analyses put isolation and loneliness on coronary disease and stroke. The American Heart Association called social disconnection an emerging cardiovascular and brain health risk. What was missing was the subclinical chapter. Can you see the artery change before the event?
The gap is real. The method is loose. They searched PubMed with keyword combinations, no year limits, and included papers by author judgment. That is a narrative review. Selection bias is built in. Purpose is fine. Design is not a systematic verdict.
Question 2: main findings, including Figure 1 and Table 1. Alex, walk Figure 1.
Figure 1 is the cascade. Isolation and loneliness turn on neuroendocrine and autonomic stress. That feeds chronic inflammation, oxidative stress, and endothelial dysfunction. Those changes promote carotid plaque, thicker intima media, coronary calcium, and arterial stiffening. Social support sits on the side as a possible modifier. They label CTRA, the conserved transcriptional response to adversity, and the HPA axis. The figure is arguing that social pain becomes vessel anatomy.
Figure 1 is a hypothesis poster, not a result. Every arrow is borrowed from somewhere else. It does not tell you which arrow carries most of the risk in humans, and it does not tell you the effect size of a friendship on a millimeter of carotid wall.
Then the mechanisms. Start with the HPA axis.
Loneliness is tied to a bigger cortisol awakening response, higher circulating cortisol, and blunted glucocorticoid receptor sensitivity. So you get more steroid and worse steroid signaling at the same time. Prairie voles separated from a bonded partner raise corticosterone. Separation from a low-preference partner does not. Perceived attachment loss matters, not just an empty cage.
Glucocorticoids can potentiate catecholamine vasoconstriction and suppress endothelial nitric oxide synthase. That is plausible. It is not proof that a lonely 50-year-old's morning cortisol is what calcifies their coronaries. HPA findings in loneliness are messy across labs, and the paper is more confident than that literature.
Autonomic system. Sympathetic up, vagal down.
Isolated humans and primates show higher urinary norepinephrine metabolites. Tissue norepinephrine can rise even when plasma catecholamines barely move, which matters for local inflammation. High-frequency heart rate variability, a vagal marker, is lower with poor social integration. Marriage and good relationships go with higher vagal tone. Isolated prairie voles lose heart rate variability at rest and under stress. Oxytocin can restore some of that. Loneliness blunts the oxytocin benefit in humans.
The paper itself says sympathetic data in loneliness are less consistent than HPA data. That sentence should have been louder. Reduced heart rate variability predicts events, yes. That does not make isolation the cause of the variability, or the variability the cause of the plaque.
Then look at Co and colleagues in ApoE deficient mice. Stable social bonds attenuated atherosclerosis through an oxytocin-mediated brain-liver axis. Isolation accelerated plaque. Oxytocin changed hepatic lipid metabolism and systemic inflammation. That is a causal animal argument, not a slogan.
It is a mouse with a genetic lipid defect and an experimental social housing protocol. Useful, not a human prescription for oxytocin nasal spray as a statin.
Inflammation and CTRA.
CTRA is increased pro-inflammatory gene expression and reduced antiviral programs. Monocytes are major contributors. Lonely humans and isolated macaques expand classical CD14 bright, CD16 negative monocytes. Leukocytes show less glucocorticoid receptor and more NF-kappa B activity, so inflammation stays on despite more cortisol. Lower connectedness associates with higher IL-6. That is a myeloid story that atherosclerosis already understands.
CTRA is a real transcriptional pattern. Connecting it to a specific carotid plaque in a specific person still takes a leap. IL-6 moves with depression, sleep, BMI, and infection. Residual confounding is the uninvited guest at every one of these tables.
Oxidative stress and proteomics.
Isolated Watanabe heritable hyperlipidemic rabbits showed more vascular NADPH oxidase activity and faster atherosclerosis. Oxidative stress eats nitric oxide. Then the UK Biobank proteomic study in more than 42,000 people. Isolation and loneliness had distinct plasma protein signatures enriched for inflammation, complement, and antiviral responses. Many of those proteins prospectively tracked cardiovascular disease, stroke, and diabetes. Mendelian randomization hinted at causal links between loneliness and some cardiometabolic proteins.
42,000 is a serious sample. Mendelian randomization of loneliness is still only as good as the instruments, and loneliness genetics are entangled with socioeconomic status and neuroticism. Treat that as supportive molecular color, not avert it.
Two large cohorts tied loneliness and isolation to faster biological aging. Persistent connectedness associated with younger AI-enabled electrocardiographic age. There is also older work on shorter telomeres. A UK Biobank analysis even tied isolation and loneliness to earlier menopause and higher mortality in women. The authors fold this into a brain-heart aging axis.
Accelerated aging clocks move with almost every hardship. They are consistent with the story. They do not isolate the vessel as the mediator.
Endothelium. This is their candidate first lesion.
In 312 adults, social isolation independently associated with a lower reactive hyperemia index after adjustment for traditional risk factors. That is peripheral endothelial dysfunction, an early atherosclerosis marker. Mechanism: glucocorticoids suppress eNOS. Reactive oxygen species scavenge nitric oxide. Vessels fail to dilate. Leukocytes stick. Separately, loneliness associated with higher soluble VE caterin. Epinephrine plus TNF-alpha dropped VE caterin through JAK-STAT and weakened the barrier. So you get both a signaling failure and a leakier wall.
312 is a cross-sectional clinic sample, not a decade of imaging. Independent after adjustment is not the same as causal. VE cadherin is interesting and still one paper in a stack. Endothelial dysfunction is a reasonable intermediate. It is not yet a treatment target derived from this review.
Table 1 collects studies of social factors and subclinical vascular disease, the rows we can defend from the text. Finnish middle-aged men, living, alone. Thicker carotid intima media after risk factor adjustment. Midlife women, self-silencing in intimate relationships, more carotid plaque. Healthy middle-aged adults, low emotional support, more plaque. NHLBI family heart study, more social support, lower odds of carotid lesions, especially in women with a family history of coronary disease.
Coronary calcium. Korean Social Life, Health, and Aging Project. It was not network size, it was low between this, meaning few bridging ties, that associated with more calcium. Swedish cardiopulmonary bioimage pilot, lack of social support associated with subclinical coronary disease on calcium imaging after conventional adjustment. Arterial stiffness, isolation and low appraisal support associated with higher carotid femoral pulse wave velocity.
Notice the pattern. Different exposures every time. Living alone, self-silencing, emotional support, network betweenness, appraisal support. Those are not the same variable. The authors admit that in the gaps section. Table 1 is a collage of related but non-interchangeable constructs. You cannot meta-analyze friendship into a statin equivalent.
You can still say the signal points the same direction across modalities. Wall thickness, plaque, calcium, stiffness, that is more than vibes.
Direction is not dose, and almost every row is cross-sectional. Arteries and loneliness can travel together because of depression, poverty, smoking, and skipped appointments.
Question 3. Do the author's conclusions seem appropriate?
Qualified yes. They conclude there is a biologically plausible link from disconnection to early atherogenesis, that animal work supports causality in models, and that evidence is still too thin for routine use in risk scores or treatment algorithms. That last sentence is the adult sentence in the paper.
I will take that last sentence. The rest runs hot. Accelerated atherosclerosis in rabbits and mice is not human causality. Plausible is the right word. Established mechanism is not. Their conclusion matches a cautious reviewer. Their figure looks like a pathway that is already closed.
Question 4. Implications they discuss and whether those are realistic. They want prospective imaging cohorts, molecular embedding studies, aging biomarkers, and trials that ask whether reducing loneliness slows plaque or stiffness.
Those implications are realistic as a research program. You can randomize social prescribing, group interventions, or even structured contact, and you can image carotids and measure pulse wave velocity at 2 years. That is a feasible trial. Measuring CTRA or a proteomic loneliness signature as a secondary endpoint is also feasible.
The implication they do not quite say out loud, and should not, is treat loneliness like LDL. Psychosocial interventions often move loneliness only modestly. The paper admits there is no evidence yet that those interventions improve vascular outcomes. Realistic implication, measure. Unrealistic implication, prescribe connection as an anti-atherosclerotic drug in 2026.
I would still put social connection on the prevention checklist, the way we put sleep and exercise, not because the imaging literature is perfect, but because the event literature is large and the harm of asking about isolation is near zero.
Asking is cheap, medicalizing is not. If clinics start billing loneliness as a vascular diagnosis without an outcome trial, we will spend money and still not know if the artery changed.
They mention oxytocin, social bonds, and a brain liver axis. Is that a therapy implication they earned?
They earned an experiment, not a clinic. If oxytocin signaling links bonding to hepatic lipids and plaque in mice, then human work should test whether social interventions move lipids, CRP, and endothelial function together. I would not spray oxytocin at lonely patients based on this review.
Agreed, for once. Oxytocin pharmacology in humans is fickle, context dependent, and not an atherosclerosis drug.
Question 5. Implications beyond the authors. What would you add?
I would add the overlap with inflammaging from our last episode. CTRA and NF-kappa B in leukocytes is a cousin of the stromal SASP story. I would add vaccine response and antiviral gene downregulation as a longevity cost of isolation, because CTRA includes that antiviral dip. I would add dementia and brain vascular aging, which the AHA statement already flagged. And I would add workplace and digital isolation in midlife, not only widowhood in late life, because atherosclerosis is written early.
Fair extensions as hypotheses. I refuse the claim that fixing Twitter habits will de-stiffen aortas. I also refuse treating isolation as a substitute explanation that lets us ignore LDL, blood pressure, and smoking. Social risk can sit beside lipids. It should not eat them.
Nobody here said stop the statin. The point is residual risk after the statin.
Question 6. Longevity and life extension. How does this review change a serious program?
It says health span is social as well as cellular. If isolation accelerates biological age, stiffens arteries, and loads calcium, then a life extension stack that ignores the social environment is incomplete. I would fund prospective imaging plus proteomics in isolated versus connected older adults, and trials where the primary outcome is pulse wave velocity or plaque progression, not only a loneliness scale. Years of life may come as much from keeping the endothelium quiet as from another NAD capsule.
It does not move my prior on maximum human lifespan. It slightly moves my prior on cardiovascular health span research priorities. Measure social connection in aging cohorts with the same seriousness as we measure ApoB. Do not rebrand friendship as a gerotherapeutic until an intervention changes an artery.
Would either of you treat social isolation as a formal vascular risk factor in clinic tomorrow?
I would screen for it, document it, and offer connection interventions alongside standard prevention. I would not add points to a formal risk calculator yet. The authors said the same.
Screen if it changes what you do for depression, safety, and adherence. Do not pretend the imaging literature already earned a guideline rewrite.
Therapy debate, longevity flavored. Alex wants social intervention as preventive vascular medicine. Dan wants measurement first. Is there a conservative middle that still takes the biology seriously?
Yes, treat blood pressure, lipids, smoking, sleep, and depression aggressively in isolated patients, because those pathways are how isolation may act. Use isolation as a risk enrichment flag, not as a new drug class.
That middle is acceptable if we also run the trials. Flags without trials become folklore.
Limitations they underplayed?
They say cross sectional, heterogeneous exposures, residual confounding, few imaging studies. They should have said more loudly that living alone, loneliness, and low support can point opposite directions in the same person. A person can live alone and not be lonely. Table 1 mixes those people.
I wanted more on sex differences beyond the family heart study hint, and more on whether isolation still predicts calcium after you adjust for depression as a mediator rather than a confounder. Mediation would change the therapy target.
Plain language recap. Purpose: ask whether isolation and loneliness show up as early artery disease, and through which biology. Findings: a mechanistic stack from stress systems to endothelium, plus a scattered but same direction imaging literature. One major figure, one evidence table. Conclusions: plausible, not ready for routine risk algorithms. Author implications: better cohorts and intervention trials with imaging, realistic as science, not as current therapy. Extra implications: inflammaging, antiviral immunity, midlife isolation, residual risk after lipids. Longevity: social environment belongs in health span research. It is not yet a life extension drug.
Last word. This is a well organized hypothesis review. Believe the event epidemiology more than the cartoon in Figure 1. Do not medicalize loneliness until someone moves an artery.
Last word. Arteries are already moving in the observational data. Waiting for perfect trials is how midlife isolation keeps writing calcium. Measure, intervene in research, and stop treating social life as outside biology.
The paper is Lee and Zia, Current Atherosclerosis Reports 2026, DOI 10.1007 S11883 026 01447 7. I am Maya. Dan stayed conservative, Aleps did not. This podcast is made thankfully to the Bio Voyager Company. Thanks for listening. One last beat before we release. If a listener is isolated and already on a statin, what should they take from Lee and Shah that is not panic and not dismissal?
Take this. Your social world may still be writing on the endothelium after lipids are treated. Ask for blood pressure, sleep, mood, and a real social plan with the same seriousness as the prescription refill. That is prevention, not mysticism.
Take this. Keep the statin, Treat the boring risks harder if you are isolated, because those are the documented pathways. Join a trial if one images arteries. Do not add an unproven vascular hormone because a review drew a brain liver arrow in mice.
That is the disagreement worth keeping. This podcast is made thankfully to the BioVoyager company.